Hi, everyone. I wanted to extend a warm welcome to those who are attending the third and final session of Bloomberg's Nursing's Black Futures Month series. We're so pleased to see such a high level of engagement from our audience members over the course of this series, and we hope it's made an impact. Before we begin, I'd like to take a moment to acknowledge the land in which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous peoples from across Turtle Island, and we're grateful to have the opportunity to work and learn on this land. My name is Shah Mohammed. I am an associate professor in the teaching stream here at the Lawrence Bloomberg Faculty of Nursing, and also the program director for the Masters of Nursing degree. Within this program, we see students who excel in their ability to center their nursing practice in leadership, advocacy, and equitable access to care. They envision a dynamic future for the nursing profession, including one in which systemic racism is dismantled. And they strive to leave the healthcare system in a better place from which they found it. Today, I'm very pleased to welcome our session speaker and Masters of Nursing alumni, Danica McPherson, a senior business advisor for the Government of Ontario, and who, as you will hear later in her talk, is the embodiment of change leadership. Danica graduated from Bloomberg's Masters of Nursing Nurse Practitioner program with a collaborative specialization in resuscitation science. She also completed an executive MBA from the Rotman School of Management and is an alumnus of U of T's Black Founders Network, an accelerator within the U of T Entrepreneurship Network. Danica has since served as a mentor for 3 different faculty programs at U of T and has proudly served as an RNAO best practice guideline stakeholder, contributor, and evaluator, as well as a member and hospital committee chair of the Canadian Critical Care Trials Group, Equity, Diversity, and Inclusion Working Group. Danica is also an after-hours clinical manager at Unity Health and an examiner within Touchstone Institute. Welcome, Danica. And I'll hand it over to you.
Thank you so much. One point of clarification, I did a MBA executive certificate, essential certificate. So just want to make that point of clarification regarding my credentials, but thank you so much for the introduction. Let's jump into it because I do have, I think, a lot to share in very limited time, and I want to make the most of everyone's time. So just to sort of frame our conversation, I wanted to provide some context to share. So the thoughts and opinions I'll be discussing in this presentation, these are solely mine at present, recognizing as we learn and go in our careers, sometimes we have new insights, but these do not represent the views of the organization, my affiliated organizations, employers, partners, or the university. I don't have any financial disclosures to declare. I will be discussing some resources and materials in the conversation, some of them of which are still on my to-read list. So these are not to be seen as sort of any endorsements at all. They're just more for informational and sharing purposes. And then recognizing there are very nuanced situations that occur. This presentation is meant to be like a high-level general sharing. I understand there's some Q&A that may come up, but really I would advise anyone to seek professional advice for their individual specific concerns. I'll do the best that I can in this conversation in the time we have together, but I really encourage people to use some of the resources that I'm going to share in the presentation. So what are we going to cover today? I have some objectives, maybe ambitious, but here they are. I'd like us to first start off, it's very important to know your history before you talk about present and future. So really starting with just a brief snapshot, not meant to be in depth, but starting with the history of Black nursing leaders and pioneers. We're going to look at the imperative for advancing Black nursing leadership. We're also going to discuss evidence and ways that we can support Black nursing leaders and further advance them. And not only that, when we do that, let's talk about the realities that we face when we are in these positions. And then we're going to explore the future of nursing and career possibilities with a case study on my career journey. So that will be our roadmap for today. So we're going to start with just, again, I said, like a brief snapshot. This is not meant to be an inclusive timeline, which I have noted at the bottom. So we know about Florence Nightingale, and I'm sure if you asked anybody, like name like a nurse pioneer, a nurse historian, the first thing that comes to mind would probably be Florence Nightingale. There are significant other nursing pioneers and leaders and innovators, Black nurses and Black leaders who we have not been told about in our curriculum. And this really does everyone a disservice. So I thought I'd take a moment to pause here and give them their flowers, their acknowledgements, because these are important names and individuals. And I do apologize for the second column. I was looking for a photo for both, and I couldn't find a verified photo, so I didn't want to misrepresent the individuals. But starting on the very left, we have the first Black nurse appointed to the Victorian Order of Canada. And this is quite significant because also there were additional barriers that had to be overcome. So for example, at the time, Bernice had to go to the States to go to school because in Canada, Black nurses weren't admitted to the education system yet. So that's something that we think about is like the extra hurdles of relocating and going to school elsewhere. She was the first public health nurse in Canada. And then when you look at the first Black nurse in Canada or the diplomas, we have Ruth Bailey and Gwyneth Barton. So these were nurses who graduated about 3/4 of a century after this nursing school opened in Halifax. So that's also quite significant. That was a significant amount of time that had passed. Um, so when you really think about timelines and achievements, like we are starting behind, and I think about that photo when you do equity, equality and inclusion, right? The school was open, but we weren't admitted. So when we actually got a chance to be admitted, we're starting further behind, years behind other nurses. So just when you think about that context in the nursing practice, moving to the next column, we have Black women who graduated from the nursing school in Ontario. So we have Marie Scott, and again, she faced barriers as well. She was denied entry. It was very difficult for her, but there's a snapshot in this article that I found that she was actually the most popular nurse in the hospital when she was admitted. So again, your organizations, when they have these limiting practices or policies, they're limiting themselves to talent. I see people in the waiting room popping up. So moving to the next column, we have significant landmark arbitration with the ONA language. And this is really important when you think about policies. And I'll talk about this. When we talk about systems level policies, these are powerful tools. And so when you have policies that that are not inclusive, that do not meet the needs of individuals, we're doing society a disservice. So at this time, Ancilla Ho Young actually filed one of the first grievances on the grounds of discrimination and racism. And unfortunately, at that time, there was no language about that in the ONA, Ontario Nurses Association Union collective agreement. So she persisted. And actually, in the year of this landmark arbitration to land that language in 1980, she also became the president of her ONA local. So not only did she fight for her job, she faced discrimination. And then when she turned to channels that she was hoping to support her and advocate for her, they didn't have that language at the time in there. So this speaks about the power of having policies that are representative. And then that final column I just added, and so I put a little asterisk by present because I was really doing historical, but this is such recent news. I didn't want us to miss the opportunity to acknowledge it. So Lily Johnson, a U of T nursing alumni, she was just recently appointed to the Order of Canada, and I believe this was as recent as this month or last month. And so she, again, was a public health advocate. She talked about the racism she experienced. She has significant accomplishments. I had limited space, so unfortunately I was not able to capture them all here, but it just talks about the pioneers that we should be acknowledging. And you know, we are where we are today, and as a Black nurse and a Black leader, I wouldn't be able to accomplish what I have without these previous pioneers paving the way for us. So I think it's really important to acknowledge that. And moving on, we'll get into some current conversation. So I really did my best to find timely evidence because we know with the pandemic, it's really changed the world. Some of the context from previous studies, people may say don't apply anymore, but the studies I found are really from the less than 5 years. So they're very recent, very timely. So this study, when we talk about diversity in Canada, and I would just lay the foundation or context first by saying it is so significant to have research and data. I can't, but to emphasize that is it's so significant to have research because this grounds conversations. It helps build your case. It helps to validate people's experiences. And so we know subjectively from our experiences of lack of diversity, but I was curious, you know, what are the numbers? And people keep talking about, you know, even after the George Floyd and these Black North initiatives, to people's companies and organizations signing that they're going to increase diversity, equity, and inclusion, like where are we today? So this was a study done in 2022 across Canada, so national. It had over 3,000 healthcare leaders, and they looked at where we are for diversity compared to the leadership in our healthcare systems and the population of Canada. And so we found, or in the study, they found that there was gender parity. So when we talk about, you know, even women getting into leadership, I guess, you know, this is a win in a way because they say, okay, we see gender parity at ministry and hospital leader level. And ministry is significant because it's provincial level. So when we talk about like micro, macro might be organizational, or sorry, meso is organizational and macro is like those larger systems, like the provincial level. So they have gender parity there. But when they get into racial, looking at the racial representation, they see that there's disparities. And, our lived experience would acknowledge that. This is what we see. I mean, I can tell you the amount of spaces I've gone through, and it's like, where are the Black leaders? Where are people who look like me? So they found that, there was underrepresentation in the leadership roles, and this even went to the highest ranking positions. So few were perceived in CEO or deputy ministry roles. And then really was more significant in the areas that had racially diverse neighborhoods. So that's something also to think about. So Ontario's quite diverse, but even when they went, across the country, like there were particular pockets of gaps. And you might ask yourself, in the context of everything, like, why does this matter? Or why is this significant? But think about the evidence that we know in research. Patient outcomes are improved when they are cared for by clinicians who represent the populations in which they serve. And when I think about previously, the ONA language, that case, that landmark case of an individual who likely before becoming the local president was not at the table when these policies were created. So there was not language in that policy to reflect her needs. And this is underscoring the importance of having people who are diverse at the table where systems, policies, and these significant documents that infiltrate and impact the entire system, you want diverse stakeholders at that table so that various needs are met. I can't tell you about the number of times when I saw patients who actually were emotional to have a Black nurse practitioner. They were like, please don't ever leave. They feel safe. And we know the history that comes with distrust in the healthcare system. So it's so significant. And there are actually studies that have shown that in neighborhoods or areas where there are racialized conditions, they have better health, the population in the area has better health outcomes. So it's not insignificant to consider the impacts of this. And what I hear when I read all these studies is this is a public health issue or a potential public health crisis because the population is not being served by leaders who represent them and know some of the cultural nuances and know their needs. And there's many doctors and clinicians and nurse practitioners, scientists who are on social media now trying to bridge that gap by acknowledging and sharing with the public how they met patients' needs, and they were glad to be there when they were because they were the only one on the team who knew, how to care for that person's hair, how to speak that language, the cultural nuances that they needed. And I've been there as well. So, and these are things that aren't always encountered in curriculums. So there is a gap in our knowledge based on our individual lived experiences. So some of the research that we know, Black nurses tend to be concentrated in non-specialty areas, and these are entry-level roles sometimes. They're in unregulated roles like health, personal support workers or healthcare aides. And, we really have to think about how do we bridge that gap. For me, I was very intentional when I started my career. I knew I was going to work in a specialty. And it's funny because as a new grad, you don't have experience. People think, you should just take the first job. But I was very intentional. Like, these are the stats, and I'm going to be in a specialty area for various reasons. I like the challenge. I knew there was more support. I even did my certificate in critical care, but it just goes to show that it's very impactful and important to have representation. So people might ask, is this a talent or pipeline issue? Maybe Black women and Black nurses are not interested in being leaders. And to that, I would say, let's discuss this slide. So we have data, again, which is very important. This is from a 2022, and 2023 global study, I believe, from McKinsey and Lean In. So every year they do a study on women in the workplace. And this particularly is North America. So Canada and America inclusive. And that is important because sometimes in Canada we lack data, and then we try to translate or extrapolate American data to Canadian context, and it doesn't always work. But this actually included data from Canada. So what did the study find? This is the largest study of women in corporate America and Canada. They collected information from about 300 organizations. They had over 27,000 participants, and they surveyed over 200 senior leaders and HR leaders. So it was quite insightful. And they talked about their policies, and it looked at the intersectionalities of women, with people who identify with disabilities, LGBTQ populations. And they found that Black women are actually more ambitious than other women at their level. And when they say that, they look at the numbers. So about 60% of Black women aspire to reach executive levels, whereas about 49% or 50% of women who desire and aspire for the same status. However, Black women are more likely to receive signals that will be harder to achieve and advance those places. And we know that the first rung is sometimes the hardest. So if you think about like science and the activation energy of chemical experiments, pardon me, that getting that first title of management or first formal leadership position can be the hardest, because once you are in the leadership track, you can build momentum. But look at on the right, what happens at the first rung for management. Black women and Latinas are the lowest. That's very hard for them to achieve. And again, it's not lack of ambition. And then people might, say, well, maybe they lack the qualifications. And I don't have this slide up of this, but there's a study in Canada, I believe Ontario, that Black people, not just women and nurse leaders, but Black people are overeducated. So we're more educated than our Ontario counterparts, but we're underemployed and we're underpaid. So again, these are two components. It's not for lack of qualifications and it's not for lack of drive. And when you add that to the conversation, it's quite significant for how you frame it. Waiting for my slide to change. Okay, so again, bringing this back to the healthcare lens, what does this mean? Why do we think about it? Why should I care? Why should you care when I ask? And again, it goes back to public health. So this is a study that was fresh off the press, February 15th, looking at healthcare workers and their experience in their care with patients if they see or experience racism. And nearly half said that they viewed racism as a crisis, and they viewed patients experiencing racism based on ethnicity, language, and various factors that are social determinants of health and beyond our control. And younger healthcare workers and those of color were more likely to acknowledge this. So this is another huge piece, because you can't address problems if you don't acknowledge or report them. So if not everyone is reporting these issues, then how can we tackle them? So, it's really important when we think about that. And this brings to Ontario context. So this slide is from the RNAO Black Task Force 2022 report. And they asked individuals, have you addressed racism and do you report it? And the column, I was very disheartened to see many people don't. And, to add context to that, they acknowledge in the report that racism in Canada is quite insidious. It's not as clear as blatant racism. So it's hard and nuanced to acknowledge. I've left interactions that I'm sure other people have where you're like, I felt off about that interaction, but I can't pinpoint what it was. Or I've had someone say you people. And I thought, do they mean you people as a Black person? Do they mean you people as staff? Like, what do they mean when they say you people always this? And so it could be those points where you're unclear, but I would say if you're ever in doubt, we're going to talk about these support groups and where you can find resources. So when we talk about strategies for advancing Black nurses into leadership, here are a few. There's many themes that come up in the evidence. Some of them are quite consistent. Number one, accountability measures. If there's anything you leave from here today, is data is currency. Data is so huge. And we have I work in digital health, so I won't even get into a rant about data, how important it is. But think about your nursing process. And I understand the audience here is very mixed. We have some PSWs, I think advanced practice nurses, directors, senior directors. But nursing process, if you go back to the foundation or basics, is you assess, you diagnose, you plan, you implement, you evaluate. How do you assess? How do you diagnose? You get data. You assess your patients, you collect that data, and you start to work through next steps. So if we don't provide data, people cannot address these issues in the system, because we're speculating, we're theorizing, we're sharing subjective experiences, but the data gives us measurable strategic objectives. If you think about SMART goals, you need data. So I would say that this is key, and I'm seeing this in some organizations, and I feel encouraged by this, because they're asking for, I've done engagement surveys, and they ask me at the end, they ask for your consent, and then they ask about your race, sometimes your age, your title. And at first, again, knowing the history of the healthcare system, knowing the mistrust that comes with sometimes racialized people interacting with systems that ask for their data. I admit, I also was like, oh, why are they asking? But now that I know the context for this, I would encourage people to think about these requests differently, because they're using data in a strategic manner. Often they ask you for the consent and the purpose of this data. So I've seen organizations that say, this is the Ontario population, and these are the leadership targets that we're going for. So they're really doing that intentional alignment to get representation in their leadership. We have diversity and cultural competence training. This, again, opens a conversation to understanding. Some people say, I didn't know that was a microaggression, or I didn't know I can't touch your hair. You know, I didn't know that I could just do this. And so when you have these trainings that give a common language, open up, you know, make unconscious bias aware to conscious, it helps to bridge those knowledge gaps, if you will. I would say 1 and 3 for me were particularly important when I thought about this, because advanced career advancement programs and leadership programs are usually invested in not only mentorship, and I would really invite people today. Mentorship is important, but if I had to choose between mentorship and sponsorship, I would advocate and ask for sponsorship. We are overly mentored. Like, we have research shows that we're overly mentored. Mentorship, and I've been a mentor, and I actually had a meeting with a mentor this morning. So I've been a mentor for 3 different faculty programs and for other individuals, and I receive mentoring still. But what you need is someone to put your name forward, someone to, you know, vouch for you, someone to advocate for you and say, I think this person stepped to the plate. I recommend this person. And then you're not in meetings to put your name forward. That is what you need. Someone to open doors and opportunities for you. And that's sponsorship. Mentorship and sponsorship are different. Affinity groups are important. These are also known as ERGs, employee resource groups. And these are a safe space for individuals who identify similarly to, you know, meet, connect, share experiences. And I know this was a theme from some of the previous discussions. You know, I think Natalie talked about belonging in her first session. The second session talked about the students' community at the university. And these are so important because, again, as I said, racism can be very insidious. And you can have these experiences that leave you questioning. But when you get into a space with other people and they're sharing their experiences, you have like a light bulb moment where you're validated, because sometimes it can feel like gaslighting where you're like, oh, someone says, oh, you were just sensitive, or that didn't happen. And you're like, really? And you feel very isolated, but then you get in a space where you're with other people who look and identify like you, and they share their experiences. And you might realize there's a common theme, or that, oh, they also experienced this. So it's very validating to be in these spaces. And if you don't have a space, create a space. And then transparent promotion processes, and I would say recruitment processes. So we know that the recruitment and talent barriers and the polls and the targets can move for different people. I've myself been in interviews where it feels like I'm on trial and they're looking for reasons to disqualify me rather than hire me. And I'm very great at interviewing. I've received positive feedback, but I share experiences with other people who are not racialized, and they get more, oh, you can learn on the job, or we'll just teach you that, don't worry, or, oh, you never done it before, that's fine. Not the same experiences where you have to prove, like, and the studies show this for women also too, that women often have to prove it, whereas men, you know, are just given like the learning stretch opportunities. So really making it transparent to remove any question, to let people know them how they're going to be assessed, just like in school, right? We have the markers for a paper, like this is what you're going to be evaluated on. So there was no question, right? It was very transparent. And then again, mentorship. It is important to have a mentor, have someone guide you through your organization, your career. I think that is also important, and so it's still noted here along with sponsorship. I'm just waiting for my slide to move. Okay, so a little bit of a lag. Apologies. So you made it to the, you know, whatever suite title position you're going for. Hooray! You want to celebrate. We got Black women in there. We feel like we want to pat ourselves on the back. We're done our jobs. We can go home. Unfortunately, not. So let's talk about the realities of being in Black leadership. Black women, compared to other women at their level, are more likely to have colleagues question their competence. They're subjected to demeaning behavior or undermining behavior. And 1 in 3 Black leaders say they've been denied or passed for opportunities because of personal characteristics. And these are sometimes vague and ambiguous, so you don't really know what the reason was. We know from the evidence and the glass cliff concept, I'm not sure if people are familiar, but people talk about the glass ceiling, and that's maybe for women in general, but the glass cliff is unique and that intersects with women who are racialized or Black. So we're often put into positions that are almost impossible to succeed. So it's like, here, you want to be a leader? Be a leader in the time of crisis where there's no staff, our budgets are cuts, there's no resources. Like it's like the chances of you winning and succeeding are impossible. And if you look at headlines now, many Black leaders are stepping down, especially in the DEI space, because you're given a title, but you behind the scenes are given no support, no resources. I've had managers share that they've been onboarded and like nobody gave them updates on their file. Nobody gave them like And then another leader comes in who's not racialized, they have a very different experience, right? So this is what we talk about the glass cliff, where you're giving an opportunity, but at face value, it's a great title, maybe an opportunity, but the experience and your resources and your support can look very different. So I call it the opposite of like the glass ceiling, because it's not above you, it's you're on this cliff, but it's still important, and it intersects with race, which the glass ceiling might not. It's the opposite of setting someone up for success. And it's really, if you think about that, that's really key. So the McKinsey report, when they talk about this, they say, it's essential to equip leaders with the skills and resources they need to be successful. And we say this about anything, students, new hires, like set yourself up for success. And we need to acknowledge that. So don't think the journey stops with filling the positions or the titles. That's not where the journey ends. It's making sure that when they get Black nurse leaders, Black women, when they get to these positions, that we are succeeding and we're supported. And so what does that look like? So here's an example I took just from, I believe this is recently published, ONA's strategic plan to address anti-racism and anti-oppression. And so, they talk about some of these things that I just mentioned, like looking at their human resources practices, looking at policies and procedures using this lens, the acronym I just mentioned, ARAO, talking about education and staff management. Like that previous table I talked about strategies is really highlighted here in an example. Looking at their processes for even recruiting board of directors into elected positions. So this is really a concerted effort, it's a strategic effort, and it's a system-wide lens. So with that information, I would pose to you to think and reflect, how will you lead? And leadership to me, as in my bio, I don't think it's a title. It's really unfortunate because it really seems to be in our system a title. And I say that because, again, I've interviewed for positions and people might say, well, you have no formal leadership experience, despite, being co-chair or chair of a nursing practice council. And I want to say kudos to that first session. Natalie actually started that nursing practice council. We didn't have it before her. That was her spearheading her leadership. But when you're in these positions and you're doing this work for qualitative improvement, accreditation, that is leadership. You may not have a title of a leader, but that is still leadership. And it's really unfortunate when you go for opportunities and people try to disqualify that experience. So, and some people, rightfully so, given what I just shared, will choose not to seek formal leadership. And I know many people, I'm still on the fence about it. I was in that party for a long time. I did not want a formal leadership position. I thought, why would I do that to myself? Like, the emotional, mental toll is so significant. But then I think about what's at stake for the system and for people who look like me. And I was not happy with what I was seeing on the front lines. And I realized I had to make a decision, and that's just my personal decision, but I would advocate for everyone to do what's right for them. But think about how you can lead and how will you lead where you are at. And this framework I share is from the Canadian College of Healthcare Leaders. So they have a framework and they break it up so you can think about how you'll lead in different areas and domains. So you lead yourself, you engage others, you achieve results, collaboration and develop in coalition, and system transformation. So as an advanced practice nurse, the Canadian Nursing Association has a definition and framework, and they talk about leadership as in promoting and disseminating nursing and healthcare knowledge beyond the individual practice setting. And that's what I tell people. I said, I was seeing patients and at a macro level that has impact, but I am looking to make systemic change beyond a one-to-one person interaction. And that's just my philosophy of lens. And at present, that may change, who knows, but think about how you'd like to lead. And you can use this framework as a resource, and there are other frameworks if this one does not work for you. So again, the Canadian Nursing Association talks about competencies for advanced practice nurses, and you'll see some overlap, right? There's self-awareness, you participate in professional development. So I'm constantly doing that. I'm thinking like, okay, here's where I am now, where do I want to go? What are my gaps? And we'll talk about that when I get to the career slide. We look at, evaluating programs, developing innovative approaches to challenges. We apply theories and we make them real into practice. We articulate our vision for nursing, and I hope we have lofty goals for nursing in the profession, and we really try to realize those. We identify problems, and we are change agents. We advise, we consult with stakeholders. So in my work and various roles that I do, I am advising, I am consulting, I am advocating for our profession. We promote nurses and advanced practice nurses with policymakers, legislators, the public. And, we have academic pursuits because I had just talked about the significance of research and how that informs these conversations we're having. So think about these, think about the different lenses and where your place would be. It doesn't have to be a formal title if you so choose. there are various ways you could lead, but keep that in mind. And this would bring me to a recent study, I believe this is, 2023 or 2022. So this is a global study, which I love because it captures, not only Canada or North America, this is global. And they talk about clinicians of the future. Like, what does that look like? So for me, I added the subtitle. That's not their subtitle, but I put potential health crisis ? Because it's both exciting and also a little bit terrifying in my mind. Are we training clinicians for the future outside of patient care? How do we future-proof the education and make sure that nurses are ready for the future? And I would ask, how do we retain nurses who want to provide direct patient care? Because they found that about 60% of students in general, but 62% of nursing students actually don't want to go into a direct patient care facing role. And so if you're on the fence where you're thinking, oh, I want to broaden my horizons and do something different, that's exciting news for you because the world is your oyster. You can take your degree and transfer those skills and work wherever you like. But the follow-up question to that for me is, who's going to care for the patients? And this number is going higher. When I did my degree decades or years ago, I knew nurses had said they never wanted to work in the hospital. And I always, pondered about that. Like, they're like, I want to work in a spa, I want to work somewhere else. And I thought, okay, like that's unique. But no, this is not unique anymore. This is the majority. People are going into nursing and medicine and they actually don't want to do direct patient care. So below the images are the paths that they're most interested in. So we have public health management, we have research, and we have business consulting. And I like the image on the right about the scientist who makes sure that when she's representing in the STEM space, or science, technology, engineering, and math space, she has her natural hair for representation to show that it's professional. So I think this brings conversation, especially this is a conversation at the University of Toronto. When we think about the curriculum and the next generation of nurses and the future of the profession, what does the curriculum look like? How do we make it more enticing for people to retain those roles in direct patient care? And I would say this only adds to the conversation about the importance of having nursing leaders and diverse nursing leaders and Black nursing leaders in spaces where decisions are made. Because we've seen what happens when nurses aren't at those tables, right? Bill 124 happens. Would Bill 124 have passed if nurses were maybe at that table? We have the working conditions we do because people who are making decisions aren't necessarily aware of the realities of nursing, and they don't have that nursing lens. So you have people making decisions about nurses and about healthcare who aren't necessarily clinicians and who aren't nurses, and they're also not diverse. So it's a whole system-wide lens that we have to look at this. It's not just, oh, it's students, because students go on to be professionals and they're leaving the profession and we don't have people caring for patients. So they're all interrelated and it's very significant. So this part I know is probably the part people wanted to hear about the most. And I found it really challenging because I thought I don't want to talk about myself for 40 minutes. But I'll do my best. I have some career highlights that I think I noted down. But what I think there were key themes that came up for me about being intentional. And again, that goes to even when you're working in these systems, collecting data, providing that data to make your strategic plan or your arguments, being intentional. And even how you address this issue, using your resources. So again, I would say those ERG groups. I'll talk about career resources on an individual and on a systems level, and then finding and building community, which sort of aligns with those previous themes and talks. So a bit about my career journey, and I tried to think about it like key pivotal moments or highlights. So I started in NICU. I started fresh out the gate in critical care. That was my decision. And I went from NICU to recovery room. And then I went from recovery room to the nursing resource pool, ICU, and recovery room. So throughout my whole career, I've never done ward nursing. I've only been a critical care nurse. But one thing I would say is I've simultaneously built a career path that was non-clinical and clinical. So I want to start that off because some people might think, oh, how do I get there? And just know that it may not start for tomorrow for you, because I simultaneously, without realizing it, I'd say in the last 6 to 7 years, or maybe 40 to 60% of my career, had non-clinical roles simultaneously while doing clinical roles. So a pivotal moment, or first one for me, is the Nursing Practice Council. Thank you, Natalie, for initiating that. That opened our eyes to qualitative, improvement, accreditation preparation, advocating for our profession, having input into how we work. And it was new to us, but it was so important, and I hope it's still succeeding and thriving, because I think it's such an important. It opened our eyes to opportunities we didn't see at the bedside. That was number one. So that was my first non-clinical role, and that gave me skills. Actually, I shouldn't say non-clinical role. I was still an ICU nurse, but I was a member, a co-chair, and then a chair of that practice council. So that was, when I look at skills I put on my resume, that was translating. Number two, I worked on an emergency ICU patient workflow working group to meet the ministry targets of pay for performance to get patients from ICU, emerge to ICU within 90 minutes. That was part of the first time I worked on something at a systems level in the organization, between departments, with teams, various stakeholders, mapping out workflows, talking about bottlenecks, and making change. And I actually implemented a new reporting structure that saved time and improved workplace satisfaction, patient safety. And I felt a new sense of satisfaction that was new to me. The Code Blue and Rapid Response team really gave me leadership skills, autonomy skills. I was working closely with physicians. I had a broadened scope of practice, and I think that's also what encouraged my nurse practitioner to pursue nurse practitioner. I was doing education with the ward staff, interacting with the respiratory therapists, teaching and speaking with patients, still doing patient flow, because if we know we have to move a patient to ICU, we have to coordinate beds, we have to facilitate that. So there was a lot involved in those roles. Clinical informatics is probably the most pivotal role I could say, and I'm now in digital health. I love what I do. I'm very happy in this role and in this space of the intersection of technology and healthcare. So I saw a role. Let me back it up. When we talk about administrative burden for clinicians, I was that person who kept sending feedback to the informatics team. I'd be charting, looking for something, I couldn't find it. I was like, why is this not here? I'm doing systems diagnosis and I had to go look down in this file to find something. I'd send them screenshots. I'm like, this is not even in my workflow. Why is this here? You're making this difficult for me. So I was very invested in our documentation to make it easier. And this was just something I did on my own time. I would just send them feedback. I saw a contract role come up. I knew a colleague on our team doing his master's in health informatics, and I actually shared that posting with him. I didn't even consider it. And I can't remember if I talked with somebody or I mulled it over, but like near the deadline, I decided to throw my hat in the ring and I said, I'm going to apply. So we both applied. I interviewed. And I will tell you, this was the most unique experience, because anyone who's thinking about career pivoting, you need to get ready for this. I can probably walk through a nursing interview in my sleep, but they asked me, suppose you had 8 identical balls. I can't remember the number. I think it was 8. One of them is slightly heavier and you're given a balance scale. What is the fewest number of times you can use a scale to find the heavier ball? When have you ever been asked a brain teaser like that in a nursing interview? But this is quite common, actually. If you look up consulting interviews, I think Goldman Sachs uses these types of questions, Google, some of the bigger tech companies. And I was thrown for a loop. And I sat there with a panel of like 3 to 5 people just staring at me as I solved this. And I think I can't remember. I think I got it correct, but they said they didn't even care that you get it correct. It was more they wanted you to walk through your logic and your thinking. And that was a curveball. Long story short, I got the position over my colleague who actually had a master's in health informatics. And the lesson I want to share there is, do not disqualify yourself. Apply. Like some people are, oh, I don't have a master's, I don't have this title, I don't have this. Apply. As I said, I've received positive feedback on my, public speaking, communication, interview skills. I interview very well. So, I could have just said, I don't have a master's. He has a master's in this specialty. I had no specialty experience in that area, and they still hired me because I had a lot of unique value proposition I talk about. And we'll get there. So when I say unique value proposition, I mean, think about what it is, your skills, everything in your toolkit, everything that you bring from your experiences. So number one, these are some broad career tips and advice. Do informational interviews. That was like my hobby. I do these all the time. I still do them now at work, actually. I reach out to people and I'm like, tell me about your journey. Tell me about your experience. Tell me about your skills. This will never be like, it's always valuable no matter where you are in your career journey, because number one, if you're considering a program like I was considering various master's degrees. I reached out to people in various programs I was considering, and some were like, I do not recommend it, or here's my experience. So you get insight before you make a decision. It can inform a decision. Number two, if you're considering an opportunity, you can get insight into the salary. You can get insight into the culture. I've ignored my gut where I've had an informational interview with a prospective teammate. It was not a positive interaction, and I should not have taken the opportunity, and I did. And I didn't take my own advice there. I did an informational interview and I had a job offer, but I wanted to speak with the teammates. and I should have not ignored my gut. So you can get insight before you make a decision about, is this the right place for me? Is this the right fit for me? Is this the right culture? And also you build your network, and you never know in that hidden job market where your next job is going to come from. So when you do these informational interviews, you get an opportunity to share your career goals. You get an opportunity to share your objectives, and someone can say, oh, I remember Danica told me she wanted this opportunity. Now it's come up. Let me reach it back out to her. So it's a win-win, and you can help people. I offer advice. I build community, and bridge those connections. It's very important. Be intentional with your skills and your knowledge gaps. Create a career plan. So, know what skills you have to offer. I looked at my clinical experience and I thought, what does this translate to outside of the clinical world? How do I articulate that to a non-healthcare audience? Do not discredit. I just talked about some of the skills that I identified in my roles. Know how to articulate that. And just like they say, take your paper and give it to someone non-nursing to read it, I would say, take your resume. And I've gone to the Career Center, and I remember thinking that their advice didn't translate to healthcare, but that was good. That was good at the time. They were giving me advice, my resume, and they were not from a healthcare background. And so if you're thinking about doing career pivots, give your resume to someone who's not in nursing. Get rid of your medical jargon. So always tailor whether it's your message, your slides, your resume, always tailor it to your audience and the objectives that you're trying to communicate. Use your resources. I heard this was, they gave me a bit of tips on what the audience wanted to hear from previous conversations. So some resources here, the Career Center. U of T gives alumni, I believe, 2 free years after they graduate. If you're a student, go to the Career Center. They'll help you with LinkedIn access, resume tips. You can do coaching. So I talked about mentoring, coaching, and it could be goal-oriented. Your workplace, use your employee assistance program. They can have career coaching, career resources. The Toronto Public Library actually offers free courses and career coaching, I think up to a certain age, maybe in mid-30s. U of T offers Coursera, I believe, to alumni. So if you want to do professional development, certificates to sort of round out your education. So for example, I chose to go back and do some certificates myself, and I did that MBA executive certificate at Rotman Essentials. That's an option. If you notice you have those gaps in the skills that you want to articulate or what you want to accomplish for where you want to go, keep a brag portfolio. So document your wins. This is very important. It goes back to data. If you're going to argue for a, opportunity, or if you're going to advocate for certain compensation, or if it takes that, here's what I've accomplished. Or even your plan. You may not have accomplished it, but you have a plan. You can say, I'm in the middle of this course, I'm doing the certificate, or I've already identified what I want to accomplish in the next years, and you're communicating that. So that makes it very persuasive. I guess I'll jump to my last point, learn how to negotiate, because those are very related. And then again, what I just provided in my career journey, apply to jobs if you meet at least 50%. I don't have time to go into this, but there's lots of evidence that women, especially racialized women, we think we need 100% of the qualifications. If you have 100% of the qualifications, you're overqualified. What are you going to learn and develop, and how are you going to grow in a role if you've done everything in that role? You want something that scares you a little bit. You want something where you're like, oh, I've never done that. I'm going to learn. At least for me, that's my personality. I like to be challenged. I like to grow. So these are just some of the resources that I can share. Happy to drop any in the chat if anyone's interested. A few books, I think on time, we're at 1:45. So I know there's Q&A coming up. And yeah, I think that's all I have.
Great. Thank you so much.